Okay, good afternoon. Glad to see you, Dr. Pierre Morgan, once more. Thank you very much for accepting this invitation.
Nice to invite
So,
me.
as I have asked you before, this discussion will be about the next generation of vaccines, COVID vaccines. What can you tell us about the upcoming vaccines, for next year for 2022? And what's the difference between the ones that we are using currently and the future ones?
No. But as I understand, there are several things going on right now. You have a few companies that have started working on a new formulation insofar as they would adapt the content, the active ingredients, to what are called the so-called VOCs, the variants of concern. And so now they have Greek letters. I think the one which is of concern is like the Delta one, I think, which is the Indian one, if I'm correct. The Gamma one being the Brazilian one, I think. Yeah, I'm getting a bit lost with this denomination, but although it was not necessarily clear with the codes, but I think we need to get used to this new, maybe less geographically connected denomination. So there will be, I think, a first part, which is this focus on, one of the, say, regional variants that emerge from one region. And especially, it will be, I think, the case for the companies that are not part of the front runners, because when they come in, it will be difficult for them to find a very naive person in the outside, either because everybody will be either immunized or have been exposed to the Wuhan strain or any of the circulating strains. So chances are both the incumbents evolving their formulation and the newcomers will focus on one or maybe more variants of concern. And again, I think it is likely to be the Delta one. But this is my speculation. Now, the other thing that you're seeing is some work done on the route of administration. There are several companies working on what is called mucosal vaccines, meaning vaccines that are administered through the airways, either intranasal or inhaled, in order to generate a first layer of protection through the immunoglobulins type A that you would find on the mucosa of the airways, in addition to generating a circulating immune response, both antibodies and T-cell response. So in principle, those presentations should enhance the level of protection by adding a first layer of protection at the level of I would say the penetration of the virus into the human body.
Okay. Is there any other vaccine that has already exists on the market that has used this new, or maybe not really new way of administration, route of administration?
Yes, mucosal vaccines exist. First of all, in terms of the intranasal vaccine, there's a well-known influenza vaccine, which is it presents as a syringe, but except there's no needle, there's a nozzle, and you spray into each nostril the liquid. So that already exists, and you have plenty of mucosal vaccines for the oral route. Hepatitis A, cholera, rotavirus are examples of oral polio vaccine, are examples of vaccines that you administer through the mouth, like something you would swallow or drink. This is something which is quite known in vaccine science, that with those vaccines you elicit not only a local protection at the mucosal level, but you also generate a circulating response.
Okay, and is it very advantageous? This is my first question. Do they have the same efficiency that the classic injection, or they're rather somehow different? They could be used probably for children. If its injection is difficult for children, maybe it could be mostly used for children or very old people.
Well, you're raising two good points here. I mean, in terms of clinical efficacy, it remains to be demonstrated, of course. We'll have to wait until the clinical results are available. But in principle, they should be more efficacious. Why? Because of this additional layer of protection. So that's the theory. It remains to be demonstrated in practice, of course, but in principle, it should be the case. The second point that you're raising is a question of acceptability by the end user. It is true that from the perspective of the vaccinee, the person receiving the product, the needle can be a decelerator in some cases. So having something which is administered through a different route, which is perceived as maybe less invasive, could potentially be a plus. I think also from the execution of large-scale programs, it facilitates the process. I mean, you're finding people knowing how to make an intramuscular injection is one thing. Administering something as a nasal spray or as a nebulized product is arguably not as hard, and therefore you should, in principle, have the ability to maybe accelerate a little bit the coverage of large volumes, a large number of population.
Yes, and what about the arrival of a DNA vaccine? Do you think it is possible that even if I think that Pfizer, Moderna, they have monopolies or duopolies on COVID vaccine market, do you think that there is a chance, there is an opportunity for DNA vaccine, let's say by Inovio Pharmaceuticals that has been working on that vaccine, can reach to the market, can have a future in this market? Yes, no, or we do not know yet?
Well, I mean, the first thing you should maybe keep in mind is that DNA vaccines predate RNA vaccines. You know, I think the research in RNA vaccines is started, what, like 10, 15 years ago, and DNA was almost 10 years prior, right? So it's hardly new. It's been tried in a number of conditions, especially cancer vaccines. Besides, they do the same thing. Essentially, what does administered DNA do is it creates it brings in the genetic material that will translate the manufacturing of the protein, which is the target protein, in this case, the spike protein, through the RNA phase, in which case then the RNA is picked up by the cell machinery to produce the protein. So essentially, if I would take maybe a bit of a maybe an abusive metaphor, I would say that the DNA would be like a prodrug of the RNA, if you will. Essentially, it's all the oligonucleotide family. The big difficulty with RNA is that it's like RNA, it doesn't penetrate very well in the cells. So the solution for RNA has been found through the formulation, you know, with those famous lipid nanoparticles, and there are other technologies that are currently being studied, such as exosomes, for instance, which would maybe raise, hopefully, less side effects than the lipid nanoparticles. But for DNA, you have to, the classical technique is to apply an electric current at the point of injection, which is called electroporation. And what it does, it changes the permeability of the membrane of the cells so that the DNA codons can penetrate in the cells and start do their job. So electroporation is a well-known technology. It's been around for quite some time, but I would argue that it is a cumbersome protocol. I mean, you have to inject and you have to apply the electric current. It is not something which is very practical when you want to immunize fast, large number of people. So maybe there is a market for DNA vaccines if they demonstrate superior efficacy and safety. But I think, honestly, if they are even with the RNA or below in terms of efficacy, I don't think there's a big opportunity for them, because from the handling perspective, from the perspective of taking care of the act of immunizing, it is going to be more complex, and therefore it will be a decelerator to adoption.
Mhm. Okay, so there are two things for the upcoming vaccine. One of them is the next generation vaccines that I have read. They are trying to reduce two injection to one. Today,
Mhm.
they're talking about the necessity of even a third injection with the same vaccines that are already on the market. So if they can reduce it into only one injection, I think it's still a progress. And the second thing is about if they can reduce the side effects. I think they have a good number of data collected from all around the world, and they can right now focus on that. Probably, I do not know if they are working to reduce the side effects, yes or no. But I know that they are working on reducing the number of the injections,
Yeah.
and just making it a habit. So once in a year, you have to be vaccinated, but yet still there are other papers that they say that we do not know how long we will be protected with this vaccine. Is there any information about how long, about the duration of the protection? Yes,
Yeah.
no.
Well, this is just anybody's guess. It's almost a crystal ball exercise. Um, uh, so, I mean, right now the debate on the number of doses is a technical debate, but it needs to be put in the context of why do you have this debate? Um, and the debate is about the quality of the protection. I mean, how efficient is the protection that you have? And second, what is the duration of the protection? What is quite well known already is that over time, and it varies from one person to another, you have a decline of the antibody titers, hence the need for a boost, meaning, propping up the level of immunity. And then, of course, you need to have at least protection against the severe cases, ideally against any case. Okay. But again, from the public health perspective, what matters the most is to avoid all those severe cases that lead to this horrible congestion of hospital facilities, and also are so clinically severe that the patients have a very long tail effect. The so-called long COVID is something which is now increasingly described and known, and it seems clearly that the like almost the effect, the aftermath of the disease is being felt for months. So it is not something which is trivial. So and the last point maybe I should mention about the number of doses is, if the epidemiology changes, meaning if the pathogen which becomes the most prevalent is escaping the immune response that has been put in place with the first generation vaccine, then by definition, you have to immunize again, which is something that we know very well. You know this for viruses, and it is the case for influenza. Um, the fact that this year the season was actually very mild is not changing the nature of the question. You're seeing this also in the field of bacteria. When you think about the pneumococcal strep pneumoniae, the more serotypes you put into the vaccines, the more you displace the epidemiology towards the serotypes that are not covered by the vaccine. It's an epidemiological shift which has been abundantly described. So in a way, when you have a protection, either you have other bugs of the same family that occupy the ecological niche, which is the case of the strep pneumoniae, or you have essentially a virus which naturally mutates. All viruses mutate, and almost by default, those that survive and keep on maintain the transmission and keep moving from one person to the other are those that escape the defense.
Mhm.
It's quite logical.
Yes. Do you think that there is a still, do we have, can we still hope that the virus disappeared itself?
I think everybody would wish that the virus disappears. I think more realistically, we're going to have to learn to live with the virus.
Oh.
Now, the question is, will it be the same virus as what we see today? Probably not. Typically for a virus, it's bad business to kill the host. Okay, a virus can survive only if the host survives. So it's okay if the host is a bit sick.
Mm.
I mean, I'm a bit cynical here, but for a virus, it's very bad business to kill the host.
Mm.
And oftentimes, when it's very much the case for zoonotic diseases, when a virus moves from an animal species in which it is well fitted, where I would say it's been there for some time, and it moves into a new species, typically it takes a bit of time to adjust. You may recall that H1N1, the beginning of the pandemic in 2009, was the cases were pretty severe. Look back at what happened in the South Hemisphere, in Australia, in New Zealand, in Chile, in Argentina, in South Africa. The cases were pretty severe. The first cases in the North Hemisphere were diagnosed during the summer months, which is very rare for influenza. And then by successive passage effects, it attenuated. And now nobody is mentioning it anymore, but H1N1 has been in the formulation of the influenza vaccine every year since 2009. So it is now fully endemic. Okay, so will this be the case for the SARS-CoV-2? I don't know. I can't tell. Maybe, maybe not. One scenario is it keeps mutating until it stabilizes, and then we get an influenza type situation. Another is it becomes completely mild, like the other coronaviruses that are giving you a runny nose and you're sick for 2 or 3 days, and that's it.
Yeah, because
But I don't think there's any consensus there, and only time will tell.
yeah, because I think with coronavirus, with the current coronavirus, we can never come back to the normal life. At university, students refuse to come back to campus because they're
Oh, really?
afraid, they're scared. They refuse to get vaccinated because they're scared of getting vaccinated. All of that. And I think last week, for the first time, after 1 year and several months, I took the metro in Paris. It was the first time after more than 1 year for me, so it was an event. I enjoyed it, but then it was scary because there were too many people pushing you, and you couldn't just,
That's part of the pleasure of the social contact in the underground.
so it is just impossible to protect yourself. Even with I was wearing an FFP2 mask, and it was very difficult to keep it because it was so hot, and I couldn't respire. It was so difficult to keep it in the city, and so it was just impossible. I told myself, if the university opens tomorrow and if I have to take metro every day, it is just impossible. That's life. It will be impossible.
Well, yeah, I think going back to how you opened this question, the question is, what will be the new normal?
Yes.
Because I think normal, the way we were living in 2009, I think everybody aspires to that. But realistically, until we have a combination of enough people being protected, a good understanding of also how we can cure the case, because you remember a vaccine is a protection, but it's not 100%
Treatment now.
there will still be, although the published evidence is extremely reassuring, meaning the so-called breakthrough cases, meaning cases that happen in fully immunized people, meaning from 15 days after the second dose or after the first dose, depending on the immunization scheme, there are very, very few. There are very few, which is how we have demonstrated that when you look at population size studies, that yes, the vaccines are clinically protective, and yes, they do prevent severe cases, and they do prevent any case, but not all of them. And so it is still extremely likely that people at risk, because the comorbidities have not changed in terms of risk factor. So still, diabetic people with hypertension, with respiratory conditions are at greater risk of a severe case. These people should absolutely be vaccinated because, especially in Europe, where summer is coming, the people are in the mood of maybe a more relaxed, less cramped, less constrained lifestyle. They want to go out. They want to have, coffees or drinks on the terrace. They want to, and therefore they're lowering their defenses. The minute
Yes.
you're more relaxed, you think less about washing your hands. You touch your face more often. If you have a mask, well, you touch the mask, but you don't touch your
Yes.
nose or your
Yes.
eyes. I mean, your eyes, yes, maybe you can, but
Definitely.
and therefore people will be less careful. And because they will be less careful, viral circulation will continue in the
Yeah,
future.
yeah, that's a very good point. Yes, definitely, definitely. So I have a last question that's a little bit long. Um, what about I think the next candidate that's supposed to reach to the market is CureVac vaccine.
Yes, it's an
Yeah.
RNA vaccine, right? Mhm.
Yes. Is there is there any chance for the other vaccines, with the presence of Pfizer BioNTech on the market, that they are occupying all of the markets and producing almost for all the countries? And do you think is there any chance for any other vaccine or Sanofi's vaccine, that we are so happy to hear about the positive results? So is there any chance for the others to reach to the market?
Well, I think first we should debunk a myth. There's not enough vaccine.
Okay.
Okay. So right now, demand vastly outstrips supply.
Hmm.
We do not have enough doses.
Hmm.
So point number one, we are not yet at a point in time where production capacity is matching demand. And we're far from it.
Okay.
Um, the second thing is the we're still working on what is the best scheme.
Hmm.
Is the best scheme full oligonucleotide, RNA or DNA, as you were mentioning before, or is it viral vector, or is it prime with one type and boost with another? And the inactivated vaccines from China, we now know a third dose is needed. China is now running a clinical study to look at boosting either with a third dose of inactivated vaccine or a third dose of viral vector. So there will be more and more data coming. So I think the fact that there is a dominant position that has been built over 1 year, essentially, by the companies that were the first to move in, doesn't mean that the competitive lines cannot move. That's point number one. The second thing is, as you said, any improvement in efficacy, although it might be a bit difficult, or safety, will be seriously considered by the authorities. That will have to be demonstrated in a context that will be much more complex when you have several options. You can start playing mix and match. Therefore, the fact that more players come in, there will be also disruption thanks to pricing.
Hmm. Sure.
So the companies that have a structure of the P&L and cost of goods that are competitive will have the possibility to make an inroad. The And I think the third item vis-a-vis the RNA vaccines is logistics and storage.
Hmm.
Even though they have improved and you can keep them in the fridge a bit longer, you still have to freeze them.
Hmm.
I mean, okay, now there are more facilities that are equipped with deep freezers or freezers, but this is a complex procedure. I think a company that would come up with an RNA vaccine that would be stable at regular fridge temperature would completely displace Pfizer
Hmm.
and Moderna if it was as efficient and as safe.
Hmm. Hmm.
So you see, there are plenty of variables that come into play. There's efficacy, there's safety, there's the conditions of use, there's the convenience to use as well, and there's price. So all those elements are not negligible. So it's a complex equation.
Mm. Yeah, but I heard that BioNTech had said that they're working, on the temperature
Of
for
course they are. They know this is their weak point.
mm, yes, temperature, and also about how to reduce the number of the injections, so they're working on both of
Yeah, but
that.
again, to me, reducing the number of injections is really not the right question. The right question is how many injections do you need at which time interval
Mhm,
to
mhm,
have the right level of protection and to maintain it.
mhm, mhm. Yeah.
If you had a vaccine that was 100% effective with one shot,
Mhm.
yes, then that would make sense. But this is not what we're talking about here.
Yes, but I think only Pfizer and BioNTech, they have access, after so many injections all around the world, they have access to a good number of data collected from everywhere, So if they really work on that, I think it will be a unique opportunity for them to keep their, uh, their
Leadership.
position on the market,
Yeah, and maybe it is the case. I mean, I wouldn't be surprised if this was the reasoning right now at Pfizer, and that's a pretty predictable, even without being aware of all the details in the boardroom. So, but again, remember what happened before the advent of coronavirus. You had four big vaccine companies.
Mhm,
Okay, Pfizer, Merck, GSK, Sanofi.
mhm,
Okay. Merck is nowhere.
mhm,
GSK is only in the game through their adjuvant with Sanofi, and arguably those two are not the front runners.
mhm,
And they actually failed their first attempt.
mhm.
And Pfizer did not invent anything. They picked the science from BioNTech.
Sure.
So the reality is the lines are moving. And so don't
Which
expect.
way? They are moving in which way?
Well, they're moving. This situation has created the perfect storm, this disruptive conditions in the market, which was otherwise pretty stable and relatively not dormant, but moving at, or the lines were moving at relatively slow pace.
Mm,
And here, what you're looking is that is a complete change of the charts.
mm. Yeah.
So I think we're extremely likely, because now it has been established that RNA and more generally oligonucleotides can play a role. Viral vectors are demonstrated as playing a role. Most likely, we will see that combination thereof plays a role.
Mm,
Those two technologies will be added to the historical technologies, which are, inactivated viruses, inactivated pathogens, or live attenuated pathogens, or conjugate polysaccharides. So you already have an expansion in the number of technology platforms that you can use to bring an answer to a pathogen. Arguably, what he said today is that, it will be faster in case of next pandemic to go through the oligonucleotides route. Maybe, um, as soon as you have the right equipment in place, as soon as you have enough facilities in place with trained personnel, right? Remember that before this situation, the people capable of manufacturing an RNA vaccine were very few. They were working essentially in startup companies. So
definitely.
it is not a knowledge which is available
No.
on tap, like the, I would say, the more traditional vaccine technologies.
Mm,
So even getting ready for the next pandemic would actually, require a bit more transformation of this industry, the creation of warm ready facilities located in the countries close to where the vaccines are needed, with trained personnel, and doing something in the inter-pandemic period so that their skills, their knowledge remains current.
mm,
It's not, you don't, I mean, you can't just dream of having a facility which is, locked and kept in the dark with nobody working in there and activated by snapping your fingers. It doesn't work that way. You need to keep your personnel trained. You need to have people, use with handling the manufacturing operating procedures on a regular basis, so that when they move from one product to another, at least they know how to use the technology, the technique, the quality control, and etc.
Yeah, definitely. We have discussed this when you were explaining the vaccine value chain, I remember. Yeah, but do you think that really the countries, at least the developed countries, they are walking in that way for preparation, developing more factories for production, or just training technical staff, or just creating new factories? Do you think, can you observe, have you observed this?
Yeah, yes, and it is already the case, and it is increasingly encouraged by various NGOs. Um, again, the old model of having a limited number of very large facilities that serve the whole world,
Mhm.
this model has demonstrated that in the case of
In
urgent situations or emergency like pandemics, they create bottlenecks,
Yeah.
and therefore they're not agile enough
Mhm.
to respond fast.
Mhm.
And so the alternative is a larger number of smaller facilities. But then for those to be meaningful and to play their role, they have to remain current,
Mhm.
meaning equipment and personnel,
Mhm.
both. And this is where the balance is difficult to find. You could dream of mushrooming facilities, but if it is create a facility to some place and let it completely mothball and have it completely unused, it will be useless or close to useless in the case of a pandemic, or it will take much more time than a facility which remains warm and therefore is ready to start operating again.
Sure, sure.
So we will see, I think, more and more of those initiatives.
Mhm.
But realistically, um, I would say only a few will fly and remain. Remember, political memory is shorter than immune memory. Now politicians are very mobilized, but when we will be back into the inter-pandemic period until the next pandemic, if they have other priorities, they will. Some of them will forget the lessons of the current
Oh,
pandemic. Well, I mean, some of the lessons of the H1N1 pandemic in 2009 were completely forgotten.
okay. So,
And
yeah,
even though it was a relatively mild pandemic.
mm, I understand. Okay, so we have to wait and see and try to change things, as much as we can. We have to contribute at our own level to just accelerate this change, this transformation that you mentioned. Okay, thank you very much, Dr. Pierre Morgan. I cut the recording.